Our next speaker is Simon Harrison. He's from Australia. He works at BiTE in Melbourne. He's one of the lead hematologists in the myeloma team. He's also the director of the Center of Excellence in Cellular and Immunotherapy, and he leads the CAR T-cell program. He also has a strong clinical focus in clinical and laboratory research. Thank you, Simon. Looking forward to it.
Thanks very much. It's always tough to follow Joe, and especially with a background like we have today. So I'll try and keep it fast and furious to keep your attention. So I'm going to talk about T-cell redirecting therapy. So CAR T and bispecifics kind of fall into this category. These are my disclosures. As we've heard today, we live in a really exciting time in myeloma therapy where there's a lot more agents in development. And so a lot of our patients have got something to look forward to when they relapse. And in particular, in this area, we've got a number of targets. BCMA clearly is the lead candidate, but there are a whole bunch of others that we've heard about today in development, and then some old friends potentially coming back in the future with more powerful agents to be able to link them to the myeloma. So why is CAR T and bispecifics so powerful? Well, T cells are really good killers. And here you can see a green T cell recognizing the tumor cell, forming an immune synapse, delivering a apoptotic hit, and the tumor cell shriveling up and dying. And during this process, you get T cell activation, cytokine production, proliferation, and if that happens with a very large number of cells, you get cytokine release syndrome and cytokine storm. But it's a very different mechanism of action that we're used to do with this. However, the myeloma is really good at driving an immune suppressive microenvironment. This was true when I did this slide during my PhD many moons ago, and it's still true today. We know that this happens because myeloma patients get infections. They have defective B and T cell immunity, and there's lots of reasons why, and we are learning more about it in terms of checkpoint inhibition and expression of other molecules that weren't really recognized during this time. We've been doing myeloma immune therapy for many years. Allograft is a very effective therapy. The problem with allograft is the 20% of people who die in the first year due to the therapy, and then the other 20% of people who have really bad graft versus host disease. So allograft and myeloma is really reserved for the very young, the very high-risk patients in certain centers that have a particular interest in doing it because it's really hard. There are other ways in which we can try and induce an immune response. This was a trial that we did at Peter Mac using dendritic cell therapy. Happens to be that we used a monocyte-derived dendritic cell, which is highly immunosuppressive, now we know. But the really interesting bit about this study is we looked at different doses of dexamethasone, we looked at a different schedule of the maintenance Revlimid, full dose maintenance Revlimid after transplant. And we did a number of different cohorts. And you can see that we improved response throughout the therapy, a very high response rate. And we have a very long tail on this curve. And the really interesting bit is the 15 people who are still in remission, 8 to 10 years after therapy on this trial, have features of B-cell immune activation. They have very high polyclonal expansion in light chains, and some of them even have a polyclonal expansion in their immunoglobulins. And so we're driving deep enough responses to see the immunostimulatory effect of Revlimid. So this is really an interesting phenomenon that we're trying to understand. So moving on to CAR T cells, the beauty about CAR T cells is you can get the T cell to recognize the tumor through an antibody binding domain, and therefore you can recognize surface exposed antigens rather than intracellular antigens. If you can tune the affinity, so you can make it attached to the target in a much more tight fashion, but you need to have higher antigen density compared to the TCR. But you can also dial up your your co-stimulation to try and get the T cell to activate. Now most of the myeloma CAR Ts are using 4-1BB. Some of the lymphoma ones are using CD28. That's a much more powerful signal. And then the people have explored multiple co-stimulatory domains, which really don't seem to add much and maybe doing antigen activation-induced cell death. So you can tune your CAR structure to try and recognize the antigen of choice and really turn on the immune system in a very effective fashion. The way in which bispecifics work is you use the TCR as your signaling domain, and you build a bridge between your antigen of choice and the TCR using CD3 and your antibody binding domain. The molecular biologists have had a field day designing all these things, so you can get really tiny ones that you have to give by infusion, like blinatumomab, and then you can get big molecules that look like an immunoglobulin molecule. And then you can have multiple targeting domains within the structure to hit 2 myeloma targets and 1 T cell target or an NK target. So there's lots of different versions of these. Ultimately, they work the same. You turn on the immune system, you get cytokine release syndrome. If your drug's working, you're going to get it. That's how it works. The downside is you might get ICANS, encephalopathy. I don't mind CRS. I really don't like ICANS. It's very scary. And then you can also get hemophagocytosis, a really exaggerated immune cytokine storm response. And very rarely you can get tumor lysis syndrome. And you can see here, handwriting is a really sensitive tool to pick up early ICANS. And that's when we move the patients to ICU. I had a patient recently with a huge degree of lymphoma tumor. They've started developing ICANS, went straight to ICU. He had IL-6, high-dose steroids, anakinra, and I was about to plasma exchange him before he woke up. So it's a really challenging toxicity to deal with. But there's an app for that. So if you want to learn a little bit about it, download the MD Anderson app. It's actually really useful. CAR T and bispecifics generate the toxicity in a much more different way. In your CAR T, you've got an armed army that exponentially increases if it's working and if it's expanding and recognizing the target. Whereas in the bispecific, you only have enough targeting ammunition that you gave the patient that will, as the T cells expand, then you basically dilute out your targeting moiety, and the cytokine release syndrome and the other toxicities wane over time naturally. And therefore, you can use steroids, get away with a lot less anti-cytokine therapy because it's self-regulating to some extent. Whereas the CRS and the ICANS is driven by the T cell expansion in the CAR T, and therefore you have to treat it much more aggressively to get on top of it. And because of that, you need a lot of help from your friends. You need to get to know your neurologist really well, your intensive care team really well, and your ID team really well, which we'll talk about later. So we're in the land of Middle Earth, and our quest starts with a legend in ASCO 2017, where the Chinese team rolled up and presented this data, and everyone goes, that's bullshit. You got this, everybody's responding, and they're responding for 2 years in these relapsed refractory populations. However, Janssen believed them because they bought the company, and but they didn't believe them that much, so they had to do the study again. The magic dust in cilta-cel might be the targeting domain. It's a camelid antibody. It's 2 heavy chains targeting 2 points on the BCMA molecule, whereas most of the rest just target 1 BCMA element. And the rest of the construct is vanilla. It's the same as everything else. Relapsed refractory myeloma was the population. They did flu-cy conditioning, and basically the way in which the patients are treated is similar to all the other CAR Ts that are around. The other element is not everybody got CAR T-cell infusion because of progressive disease or other problems during the manufacturing process. So there was a fallout. Heavily pretreated, maximum a median of 6 prior lines of therapy and lots of refractory disease. Everybody responds. This is unheard of. So as we heard before, this is disruptive therapy and everybody's having a very deep response. And this slide was updated recently, and it's out past 24 months, and I think approaching 30 months as a median progression-free survival. So this is changing the ballgame significantly. The toxicity, as we said, CRS, most people are getting it as part of the deal. You have to just control it. But there was a late signal of late ICANS, which is this really very unusual, actually dirty secret in the CAR T-cell field, where it does happen in the CD19 CAR T-cell field, where you get this odd Parkinsonian type syndrome. Patients become obtunded and often succumb to the therapy. It's very hard to treat, but it's driven by excessive T-cell activation and proliferation. And if you can bridge the patients effectively, then you can avoid that toxicity. And so bridging therapy becomes more and more important with CAR T-cell therapy in myeloma, even than in lymphoma. And so that cell has been approved in the FDA this year. What about poor risk, even more poor risk patients, functional high risks? So this is the CARTITUDE-2 data, and these are patients who have progressed within a year of diagnosis. Primary endpoint of this is MRD negativity, but the study design is pretty much the same. The characteristics are nothing too exciting. They basically all had one line of therapy. Most of them have had a transplant and have progressed within a year. Everybody responds. And the really interesting thing is their second response is longer than their first response. And that's really a game changer in this population, where you're able to reverse the poor risk functional biology in these patients by changing the mechanism by which you're treating the patients. Toxicity is nothing exciting, but this is a really important study. Earlier lines of therapy, bad risk disease, early progressors will benefit from these kind of therapies. And this is the pipeline for the CARTITUDE study. So going earlier and earlier, 1 to 3 prior lines of therapy, CARTITUDE-4 hopefully will read out later this year. And then transplant ineligible or deferred. In my experience, all of the patients should have been having a transplant, but they're being deferred. So the study population is a bit contaminated. And then the EMN study looking at badges CARTITUDE-6 in the truly transplant eligible population. And then I'll talk about this later, but we're doing a study with Janssen in extramedullary disease and looking at CAR T-cell tracking in vivo to see whether the CAR T-cells make it to the extramedullary disease site. So what have the competition been up to? So BMS clearly have their baby, ide-cel. The way in which the study has been done is pretty similar to the CARTITUDE-1 population. Again, highly relapsed and refractory population. You'd expect to do badly. The more you give, the better they do. And the earlier line of therapy in which you treat the patient, the deeper the response they get, and therefore ultimately this improves progression-free survival. But clearly, the depth of response matters. If you achieve a CR, it's almost like a binary setting in this data, that you're either in CR or you're not. And I think that's where we're going in myeloma with these immune-based therapies, where driving to CR and MRD negativity is really the new goal. Traditional predictors of response sort of hold true in terms of high-risk genetics and extramedullary disease, but for some reason the older patients did better in this study. I don't understand that, but it's really quite interesting. There wasn't a particular signal in CRS or neurotoxicity, but there is a consistent signal across all of these platforms of infections, and we'll talk about that later. And this was the first CAR T-cell therapy approved last year. Try and get try and get hold of some. That's pretty tricky. Manufacturing capacity is really challenging. And there are multiple studies in this phase. And then there's also the next CAR T cells product, which is shorter manufacturing, and they've altered some of the other elements in the program. So poor T cell expansion and persistence is one of the mechanisms of failure. And you can try and change the phenotype of the product to try and have a stem cell memory type phenotype, because they seem to expand and persist better. The Janssen product seems to have a better profile of this compared to some of the others. And the Bluebird team have tried to achieve this by using co-culture with a PI3 kinase. And you can see in the panel on the top right, if you do a re-challenge experiment, the new therapy, which is the blue line, continues to reject a second tumor, whereas the red line, which is the standard produced cell, isn't able to do that. And their product does change the phenotype of the cells, but it doesn't seem to make too big a difference in terms of response rate or duration of response. So it's not the whole story. One of the other mechanisms of loss of CAR T cell is immunogenicity, and you can try and humanize the BCMA portion, which is what the Spanish group have tried to do here in their study. The other thing that they've done is to try and minimize the CRS and using the fractionated dosing of the cells in line with what the UPenn group do as a routine. And they're also trying to redose the patients at 4 months. Everybody responded. It's a consistent signal with high levels of deep response. And the really interesting thing here is the efficacy, the progression-free survival is in keeping with other products around here, but there's a significant signal in extramedullary disease, which has been thought to be a poor predictor of disease control. The persistence doesn't seem to be that different. What you have to remember is T cells are designed to expand when they see antigen, and if there's no antigen, they go away. And they're supposed to do that. And that's one of the things that we often forget. It's in their natural biology. But 24 patients had reinfusion, about half of the patients expanded, and about half the patients who had measurable disease at the time of the reinfusion deepened their response. So there is something in this in terms of going in and trying to get a second bite at the cherry. One of the problems with CAR T cell therapy is the time from order to delivery of your product, and how do you bridge the patient to be ready? So, we have to send our product halfway around the world. Sometimes we can send it to the 9th floor for our in-house production facility, but this is a real challenge. So can you get off-the-shelf allo CAR T? And there's a number of groups trying to do this. You take a donor, you expand the product, you manipulate the T cell population to stop graft versus host disease and prevent graft rejection. And both the Allogene and the CRISPR people have been trying to master this. Allogene are clearly ahead because they have quite a nice response rate. There was a bit of a scare because of some cytogenetic abnormalities in at least one of their patients, caused an FDA hold, but this was removed in January and this program is ongoing. So I'm going to change tack here. I'm going to talk about bispecific antibodies. And this is one of the early studies that we were involved in using AMG 701. 701 is a modification of the AMG 420, very small molecule that was given by infusion. And they've added an FC domain onto this to try and make it hang around a bit longer. And this allows weekly dosing in the early phases and much more prolonged dosing later on. The original molecule had a funny toxicity signal where it caused peripheral neuropathy. And therefore, we were wondering whether this was going to be the case with this molecule, but it doesn't seem to be the case. Again, heavily pretreated relapse refractory population, and nothing unusual about them. But the safety profile is really quite good. Grade 1 or 2 CRS in the majority of patients, a few deaths mainly due to infections, and there was one acute cardiac toxicity that caused the program to go on hold for a little while. But overall well tolerated with a very high response rate at the optimal dose. We're still fluffing about with how to deliver this therapy with step-up dosing and things, and there's also a program to move it into subcut dosing. But the really interesting thing here is that depth of response is really high or low, depending on which way you want to think about it. But the duration of response is really quite long. Top patient is one of my patients. She had 13 prior lines of therapy, 2 previous autografts, 1 allograft, and a bridging autograft to get onto this study. She's never been in CR before. She's been in CR for 4 years now. She ran out of super and had to go back to work. She got one of the lowest doses of therapy on the trial, one of the very early dose levels. And the reason why she responds is she had the lowest recorded soluble BCMA level in the whole study. So the sink effect didn't need to be overcome in her case. And therefore, that's one of the challenges with using BCMA, that you have to overcome the circulating level of BCMA when you're trying to attack it with an antibody, which doesn't seem to impair CAR-T. So it's a really interesting phenomenon. So teclistamab is the poster child of this at the moment. This was in the New England Journal recently. And the Majestic-1 study population is kind of similar to everybody else's. Quite an older group in this study, and a high proportion of Penda refractory, and everyone was pretty much triple refractory. A really nice response signal. So you've got 63% of the patients responding and 40% are in CR. Extramedullary disease and ISS stage 3 are really the only predictors of response in this study. And the duration of response is over 12 months. And I think that's a really interesting first cab off the rank in this highly refractory population. And as with the G701, the CRS signal is really relatively modest and not much in the way of ICANS. So this is changing the ball game in myeloma. So what about in people who've been exposed to prior BCMA treatment? They use this agent in that population. You can see most people had had an antibody-drug conjugate prior to this study, and the response rate is pretty decent. You've already hit the BCMA once, and you're able to do it again using a different mechanism of action, so you haven't downregulated the target particularly. But one of the things Joe didn't talk about is one of the proposed mechanisms of action of belantamab is this immunogenic cell death. So you are probably already priming the immune system to target BCMA with that. But we've been able to redirect the T cells towards that in a very strong way, and the duration of response is really long. So it is possible to target BCMA on more than one occasion. And if you go in earlier lines of therapy, do you want to use it in combination with daratumumab? So Dara was given at the normal dose escalation, again, triple refractory, and a significant proportion of these patients had been pre-treated with Dara. The toxicities are really nothing to take home about, but there may be an increased signal of cytokine release syndrome and more grade 2s than you would do with a single agent. Not sure why that is the case at the moment. It may be that taking out some of the NK cells or some of the regulatory T cells is what's driving this. The response rate is seems to be higher than with single agent, and the duration of response, again, in keeping with all of these other modalities, is really impressive. So it is possible to use these agents in combination, and it remains to be seen what the financial toxicity is going to be when we actually get there. As I said earlier, the molecular biologists have been re-engineering these molecules, and this is a 2 for 1, so 2 BCMA binding domains and 1 CD3 binding domain. And this slide illustrates this is hard work for the patients. The first 2 or 3 months of these therapies, the patients are full-time members of the team. I always say to my patients, you are now an official member of the myeloma team. You get to report, not interpret. So they have to tell us what their symptoms are as they occur and not do the usual thing, we'll see what happens tomorrow. We always have to report today. Anyway, so hard work for the patients to be on these studies. There is the cytokine release syndrome in this study seems to be higher with a higher grade of cytokine release when you get up to the effective dose levels. And here you can see the threshold effect that I talked about earlier. You have to get high enough up the dosing of the molecule to actually reach the threshold of response. But once you get there, it's almost like a switch. And you can see when you get to the effective dose rates, this molecule seems to have a higher rate of response at around 90%. So you have to manage the toxicities, but you're kind of trading off efficacy for toxicity. I really like FCHR5 as a molecule. It's really cool. It's this massive big molecule, and what the company have done is map the thing all the way down and pick the sweet spot to where the best immune synapse occurs, and it occurs targeting an antigen right at the cell surface part of the molecule. So it's really fascinating science. Call me a geek if you like, but there you go. I'm in good company. So we've been working with this study since its inception. It's a vanilla construct, so it looks like an immunoglobulin molecule. Very refractory, high-risk population in this study. And you can see that the CRS, most people are getting some CRS, but it's relatively manageable, mostly grade 1 and 2, the odd high grade. But you can see there's a clear infection signal again in this study. So the overall response rate is pretty modest at around 60%, but that has to be reflected in the population who went under this study with a very refractory high-risk population. So again, we're fluffing around with dose escalation, step-up dosing to try and get rid of this cytokine release syndrome. I think they're barking up the wrong tree, and the FDA is driving that, unfortunately. But really interesting molecule. And then the last one is GPRC5D. They get to be a bit of a mouthful. Again, very highly expressed and upregulated in smoldering and symptomatic myeloma. Oops. And you can see that they've been trying to look at either low dose weekly or high dose twice a week therapy once you get through the step up dosing period to try and make life a little easier for the patients. Again, heavily pretreated population. And the really interesting thing about this molecule is it's expressed in the skin and probably in the gut as well. And that's driving the toxicity. And the Grace molecule that I'll talk about in a minute, there's this very significant nasty skin rashes and dysgeusia as the main toxicity, and it's much less a problem than cytokine release syndrome. So the CRS grade is again manageable, nothing too exciting, but the response rate is in the 70% range. A non-BCMA target with a high response rate, that's really exciting. So you can go BCMA, non-BCMA, or you could potentially go BCMA, non-BCMA in one therapy. So we need to wait and see how this is going to pan out. And again, as with these other things, if you get a response, it's maintained for quite a long period of time. This is a molecule from Roche, and again, it's a 2-for-1 molecule, two binding sites and one CD3 binding site. Again, modest CRS signal, lots of skin toxicity, but a 70% response rate. So these molecules are really panning out across multiple trials of being a valid target in multiple myeloma. The action happens in the first month. All of the myeloma is being cleared from the bone marrow in the first month. In one of these studies, we did bone marrows on day 8. And David Westerman, our pathologist, rang me up and said, this lady had 100% myeloma when you started, and now that I can't find any, have you got the right patient? The clearance is just amazing. And the fact that they don't get they don't get tumor lysis syndrome is really interesting. Why is that the case? But 2-for-1 probably is more effective than the 1-for-1 binding. You may pay for that in terms of toxicity. And you can see here, across the modality of the bispecifics, high response rates, relatively modest CRS signal that's relatively easy to control, and little neurotoxicity. So tumor heterogeneity is a real problem. One of the things that we talked about this morning. This is a mouse model where we've got all of these different clones being generated in a VK-MYC mouse model. And you can see beautifully with my collaborator Ed Hawkins that we can model this, looking at this is the skull in a myeloma mouse, and we can track this over time. My PhD student, Jeremy who was the myeloma fellow last year, is humanizing this system. So we're taking human myeloma, putting in a human immune system, and using that as a tool to model the therapies that we're going to be doing. So that's going to be really exciting. But as we heard earlier, BCMA loss variants do occur due to deletion 16p. And there are ways in which we can try and target multiple antigens, so dual targeting with CAR-Ts, for example. Can you use a CAR and a bispecific? That's to be proven. But one of the advantages of using a bispecific is that you may be able to get dual targeting. You may be able to get a second episode of CAR-T cell expansion if you give the bispecific antibody second. But you need to be careful, because what you don't want to do is overdrive the system and cause activation-induced cell death. And there are some other reasons why you may not want to give the bispecific antibody first, because of increased exhaustion markers, downregulation of CD28, and a whole bunch of other things that may affect the product in production. So if you're going to give your BCMA before CAR-T, you need to collect the T cells and manufacture your CAR before you give the antibody, in theory. Yet to be proven, and we're trying to do that trial. So if you have impaired T cell function, which we know we have in myeloma, what about other cells? So we can look at NK cells and macrophages, and those studies are ongoing. And you can also use bispecific antibodies to engage NK cells and to try and avoid some of the functional problems. There may also be an added benefit of less cytokine release syndrome and other toxicities. That may or may not be true, and we're just working out what's happening. The last thing I'm going to talk about is trafficking. And we've talked about T cells being able to penetrate the tumor, and this is another image from the Hawkins lab where you can see in purple myeloma. The green is the myeloma and the purple is the CD8 cells, and you can see there are some areas where you've got T cell infiltration of the myeloma and other areas where you have very little. And can we change that trafficking over time using different ways of making the T cells be able to get into the tumor? Radiotherapy might be the simple answer. Make the tumor microenvironment more receptive by disrupting it with radiotherapy, for example. We talked about extramedullary disease as being a poor risk factor. Do the T cells get there after we put them in? I don't know. We think they do, but we've already seen that extramedullary disease is a poor risk factor in these immune-based therapies. And so we've developed an iron nanosphere doped with a PET tracer that we can load into T cells, CAR T cells, and then give them to the patients and see where they go with a PET MRI. So here's one of the first patients who was treated with our in-house CAR T cell program targeting Lewis-Y. And you can see that we can traffic the cells through all of the usual compartments. So it goes through the blood, the bone marrow, liver, lungs, and spleen, or in a quite expected pattern of migration. Unfortunately, this CAR T cell product isn't very effective, and therefore we haven't got that killer image where we can show the lump of tumor surrounded by the T cells yet. But we are doing this in combination with Janssen, using the cilta-cel product, hopefully to dose the first patient this year. So that's going to be really exciting. So in conclusion, CAR T-cell and bispecific antibody therapy in myeloma is here to stay. Managing the toxicities, stopping the patients dying of the therapy is really important. The relatives don't really thank you very much if the patient doesn't go home. Atypical infections are an emerging problem in myeloma. I'll touch on that in a minute. And studying earlier lines of therapy and in novel combinations are going to be important to work out how you use these tools. I personally believe there's a path to cure using these therapies, particularly in the low-risk patients. Whether you can get over that hump with the high-risk patients, I think remains to be seen. But I think this is a really exciting time to be working in myeloma. But a word of caution. So we've had a special interest in infections in myeloma for quite a long time. So I went to the ID meeting a few years ago where they were talking about infections in myeloma. And I said to them, you guys better be ready, because there's a tidal wave of infections in myeloma patients coming your way. And so we developed a relationship with them. We had a PhD student who's one of my colleagues now, Ben Tay, and we've looked in the bispecific patients more recently. So these are aggregate data, 39 patients treated with bispecific antibody therapy, and about 90% of them have had emergent infections. There's all sorts of weird and wonderful things coming through, a lot of upper respiratory tract infections, as you would expect, but you're getting reactivation of viruses in this patient population. These patients look like allogeneic transplant patients. I've had one patient who's had a non-tuberculous mycobacterium, CMV esophagitis, and BK viremia all at the same time. So this is really, treating the myeloma is hard. Stopping them dying for infections is just as hard sometimes in these heavily pre-treated populations. So I'm going to stop there. I want to thank the team who have helped along the way do all of this work, and I'm happy to take any questions. And I'm only 2 minutes over, so not too bad.
Thank you, Simon, for your comprehensive talk on CAR-T and BiTE. We have time for questions. So we have a question from Henry Chan. Henry, do you want to ask?
Oh, so on one of your earlier slides, you demonstrated that the antigen density needed for T-cell receptor was, I think it was 1, but then for CAR-T, it was more than 100. So does that mean that potentially bispecific is more resistant to, well, you're less likely to get resistance to bispecific because the cells can't downregulate the antigen as much?
So that's an interesting question, Henry. I mean, when you signal through the TCR is normally seeing the antigen in the context of MHC. Whereas when you use a bispecific antibody, you're bypassing the MHC recognition by sticking an antibody in its place. And therefore, you're actually seeing the same antigens at the same density because it's an antibody binding domain that's doing the work. So I don't think that's as relevant as it might be, but it may increase the sensitivity of the cell to turn on. But what we do know is the CAR is much stronger at turning on the T cells and causing T cell activation than the TCR. And the TCR effectively goes to sleep in these patients who are in CAR. So you don't really signal effectively through the CAR. And whether that's a similar phenomenon that's happening in bispecifics and that's what's driving the infections, I actually don't know. But what I think is happening is you get T cell energy at certain points of the disease course. So I don't think it's as simple as antigen density, Henry, to answer your question.
I think there's a question from Rob Feinkoff on Facebook, so I'll just read it out. So total patient numbers could become large with earlier lines of myeloma and lymphoma treatment with CAR-T therapies. How many centers are seeking approval for CAR-T cell delivery in Melbourne?
So at the minute, there are 2 centers delivering standard of care therapy, and that's probably enough for leukemia and lymphoma. When myeloma comes on board, there's going to be a 3rd site added, and then it remains to be seen how many sites we'll need. Probably 3 or 4, I would imagine, but it's going to be hard to predict. What we do know is this numbers of patients seeking CAR therapy at the moment is significantly lower than anticipated, and it's about it's less than half, and that's an international phenomenon. It's not really sure. It's not really clear why that is the case. Simon?
Simon, just first of all, congratulations! Like, such great work. Like, really, you know, from I remember when you sort of started down this path and what you've managed to achieve. It's been really, really extraordinary. So well done. I am very interested in the infectious complications. I think we're increasingly seeing difficulty with infections. I recently lost a patient with that had cryptococcal bacteremia who's on daratumumab with a renal transplant. So it's very, very high in my mind at the moment. Would you be giving IVIG regularly to these patients? Is that a silly thing to do? Would you be giving, you know, what would be your thought process about how we can mitigate some of these infectious complications?
Yeah, so I think all of these patients should be on IVIG because they all have low normal immunoglobulin levels. We have an active prophylaxis program, so all of them are on Bactrim, all of them are on antivirals, and a significant proportion are on antifungals. Now, whether that's fluconazole or posaconazole, it partly depends on the line of therapy and what they've had. But, you know, as Joe said earlier, bridging therapy is becoming an increasingly common thing that we do to get these patients in a good enough state to actually get onto a trial or get onto a standard of care new therapy that's highly effective. So I think, you know, we're giving PACE, we're doing rescue transplants, doing all of these slightly odd things that you would think, why are you doing that? But the problem, you have to get some degree of control before you can turn the immune system on. Because if you just lob in one of these treatments, the patient goes up in a puff of smoke, and it's really hard to deal with it. So having a degree of control of the tumor doesn't actually matter what you do, as long as you do it, and then go in with your definitive therapy in a calmer fashion. But that's why, another reason why we're seeing lots of weird infections. I think last time I was on ward service, we had 3 patients on the ward with cryptococcus.
Thank you. Any other questions?
Simon, I have a question. Will you accept patients from New Zealand? Can we refer patients to you?
For what?
For CAR-T.
So we've had a number of patients referred for CAR T-cell therapy from New Zealand. So the high-cost drug program has allowed a number of patients to come across. That covers standard of care therapy only. It doesn't cover trial therapy. In terms of trial referrals, we can treat patients on trial from New Zealand. The problem is some of the standard of care costs are not funded, so the patients have to find that element of their funding sometimes. What we'd really like to have is an arrangement with the New Zealand government to actually cover the standard of care costs, and I think that's something that we've been trying to pursue over the last few years to facilitate trial participation by the New Zealand patients. But the short answer is maybe.
Thank you. Any other questions?